Thank you very much, Jacques, for the invitation. So I will talk about the results of the recombinant chorionic gonadotroph treatment in young women with BRCA1 and 2 germline mutations. And so we will discuss what we have done in the clinic just on the on the basic idea of Professor Russo. So to start my talk, I want to acknowledge somebody. So yeah, we know that if God exists or not, we cannot answer the question, but I can answer one question, that there are some angels on earth. I'll just bridge down. And these are two people I want to acknowledge, as Professor Russo and Professor Janssens. As Professor Russo said, we came across each other on a conference organized by ECP, by Professor Janssens, and we talked about the study, and we really felt that it was a feasible project, and so we had a very generous support by Think Pink, and so we went on with the study. And also I want to acknowledge Peter Sieprat, who is on the board, and Erik de Jong. So we set to do the study, and the first thing we had to convince the government to apply HCG. So we wrote the protocol that we were going to give HCG for 3 months to young women, and we waited for about 3 months and we didn't have any answer. And I said, why has nothing happened? So I called the government and had a very friendly lady. She said, but doctor, you know, HCG is to produce an ovulation, and you give it once a month, and you are going to give it for 3 months. But I said to this woman, well, if you open the protocol, then you will realize why we do that. And I explained the whole protocol and said, thank you, now I understand it. And so she opened the protocol, she read it, she was very enthusiastic, and she really approved it straight away, and then it got through the ethical commission. And so once we had taken that hurdle, we could progress with the study. And since then, everything has been very well on, and it was a very nice collaboration with Professor Russo and Professor Janssens, always enthusiastic and always very energetic to support. So basically, if we come to breast cancer, we know that in the total population we have, and that's virtually the same in every country, we have about 2.5 breast cancers per year from the age of 50. And so we have different types. We have a low population because we don't recognize them. We can't really see where these patients are, but there is a low risk population where there's only half breast cancer per 1,000 per year. And there's also a high-risk population where there is maybe 10 breast cancers per 1,000 per year. And so we use radiology. We say these are dense breasts, and we really focus on certain groups. We know we have BRCA, and we heard from a meeting yesterday that there may be some populations, other genes that are coming, and they may really entail a story where we have about 30% of women which could explain with the genetic formations that could entail breast cancer. But up to now we have these two populations which we try to distinct. But of course, this is detection of breast cancer. So it would be nicer to prevent it. And so we know the breast risk factors. We all know that early menarche is a risk factor. If you have start menstruating early in life, you have about 20 to 50% increase. If you have a late menopause, you increase the risk of breast cancer. If you have a pregnancy quite early in life, it seems to protect quite well. And then another important thing that strikes as well, if you smoke early in life, it seems to increase the risk of breast cancer. And if you look at all these risk factors, some are really linked, and the smoking at young age and the early menarche and the late pregnancy, these are all related, and we have heard it very eloquently from the talk of Professor Russo, that in fact these may be very linked to each other. So just a moment, yeah, we know that at birth, boys and girls, they have the same nipple and little glandular development. We know that there is a little bud formation behind the nipple, and that's very primitive. It's very, very simple. But then something strikingly happens at puberty. We see that due to female hormones, that the branching is increasing. There's more branching. There's more acini coming into that system. And then if there is a pregnancy, we see that there is even more development of these branching and more development of acini. So this system becomes more complex. And so that's what we call a lobular tree. And then once women are lactating, there is lobular 4 originating. So starting from very simple structures which are equally formed in young girls and young boys, we end up with a very complex structure, lobular 4, in lactating women. Very relevant to that, if you look at the KY index, so the proliferation index in these cells within these ducts, you can see that, for instance, if you have a lobular 1, there's a proliferation which is about 20 times higher than the proliferation in the lobular 3. So this is an important message, and this is perhaps an answer to your question as well. So if we look at young women that are nulliparous women or parous women, there is a differentiation. We have parous women have more lobular 3, and nulliparous women have more lobular type 1. But the fact that we have to acknowledge that if you have a gene and there is a mutation, and this mutation takes place, well, what happens? Or you have lobular 3 with a low proliferation, and so if there's a low proliferation, there is more time for DNA repair before, in fact, the division is taking place. So if this carcinogen, there's a low proliferation, you see there's more time for repair, and what happens? This repair actually repairs and does away with the carcinogen. So, in fact, if you have the cells that are arising from that, there are normal cells again. So, if you have low proliferation very early in life, then in fact the accumulation of mutations is reduced. Because if you have a long period, for instance, from the age of 12 till the age of 35 when you have your first pregnancy, well, then you have an extended time where there is high proliferation with a lower chance of a repair prior to actually division, and so you end up with more mutations. So, and if this period is prolonged for a long time, not between 12 years and the pregnancy of 20 years, but between 12 years and 35, you have that long period and you have more accumulation of mutations, which then at a later stage will give rise to your first actual cancer cell, which give rise to your breast cancer that is going to be detected by the radiologist at the stage of 5 or 6 or 1 centimeter, 5 millimeters or 6 or 1 centimeter. So this is, the shorter this period is becoming, the less chance of having an accumulation of mutations. So, having heard the talk of Professor Russo 3 years ago, and with the support of ECP and Think Pink and Professor Jaak Janssens, we sat together and we devised a protocol where we could really test the hypothesis that was put forward. So we selected women with a high risk of breast cancer, and we explained the study. We explained how it works. So I saw every patient explaining them for a half an hour, together with their boyfriends or with their parents. And so we explained the study, and I was really, it was amazing how mature these women were. They were already thinking about a lot of things. They have read a lot of things. They were looking into operations. They have been following meetings. So all these women included in the study, when they heard the protocol, they say, well, we are going to participate. They were very mature, and I respect them very deeply because they were young women that had to have 3 biopsies and agreed to inject themselves for 3 months. On top of them, they should not take oral contraceptives, so they should protect them with condoms. So it was really a very tough protocol for these women, but they accepted the protocol, and so we were able to recruit quite quickly. So the protocol was that we had an ultrasound of the ovaries and the uterus. We had a blood test done, and then we did a biopsy. After that biopsy, we did every month ultrasound and blood taking for the uterus to see what happened, because there is no real study that have been given HCG for a prolonged period. And then after 3 months of injecting themselves with HCG, we did a second biopsy. And then to really see if there would be some changes epigenetically in the breast, we had another biopsy 6 months later, so to see whether the changes that are going to take place, whether they would be prolonged. So this is a breakdown. That is an answer to Jack Cusick's answer. We have a breakdown of all the mutations. We have in that BRCA1, but also BRCA2. And so this is a list. These 2 were karyotyped in a different lab, so we are going to collect the data in a few days. And you can see that we omitted 1 line here. The numbering is stopped. And this is actually a young woman that went on the program accompanied by her mother. And so she accepted, she did a biopsy, but after 2 months of HCG injections, she phoned us and she said, I have to say something in personal. I had an abortion early in life, so I couldn't tell it because my mother was present at inclusion, but I feel that I have to tell you because it's a very important data. So we decided to not include that patient anymore in the study for future analyzing of the results, but we included her, we continued to include her because she may give a clue what happened after an abortion, because she aborted at the pregnancy of 11 weeks. So we still follow her up, and we're going to analyze the data, but she is not included in the series. So all these women had to have biopsies, and we did the biopsy with the needle developed by BioIncise by Jack Janssens. It is a bigger needle, but it has the advantage that it doesn't click. And I have done all the biopsies, that's more than 70, in these young women. And these young women, I have them done personally, and I can say that not one procedure was painful. So it looks a bit awkward, but the women were constantly talking. They were well perceiving the procedure. So the procedure is like that. We anesthetize with 26 gauge, and so when the skin is anesthetized, we go into the breast area, and then we do an incision. Then we insert the needle. You can appreciate it's a needle of 4 millimeters, so that's thing. Then we have the spirotome inserted because it doesn't click. The patient doesn't feel it. So we gently screw the needle inside. Once it's on this marker, we stop, and then the biopsy is in fact cut with the outer layer. So, and we go until we have the final thing, and then we put it out, and then we have a device. So normally you close it, but just to see the biopsy coming out, so that we have enough of tissue to put into ethanol and to in RNA later. And then it was sent to the lab of Professor Russo, so he had all the biopsies available. And so if we look at the data, all women that came into the study had to of course, stop oral contraceptives because we didn't want any interference with what hormone soever. Intrauterine devices were allowed to continue, and one woman had a copper IUD, so that was allowed as well. So we were the first to use HCG for a long time in young women, so we were a bit reluctant at first, but we wanted to be assured that they had no pregnancy symptoms. We wanted to show that there were no going to be hyperstimulation of the ovaries. So we looked at the ovaries, we looked at the endometrial, and we looked at the type of endometrium. We looked at the complaints, and what we saw that because a lot of women came off of the pill and had some PCO-like ovaria when they went on the pill, that the PCO system was again reinstalled. So the thing is, if we look at the endometrial aspect, we saw that a lot of women had a very thin endometrium or an irregular endometrium of about 2 or 3 millimeters, or a not accessible pattern. We were able to see whether it was triple lining or whether it was luteal, but a lot of women went into that group where the endometrial was not as a category could be categorized. So if you look at the endometrial thickness, we saw that in fact when it came on the study it was 4 millimeters. It was after 1 month it was 3 millimeters, then it was up to 4 millimeters and then to 5 millimeters. So we saw that in fact a lot of women kept on cycling. And so we have all the blood tests to see whether ovulation was take place. And of course the blood is going to be used to have the concentration of HCG that we obtained. And we are now in current to see what concentrations are important. So as showed by Professor Russo, we have the timeline that every woman has been included in our study. And we are now performing the last biopsies, so at month 6. So normally all the biopsies are sent to Philadelphia and they are analyzed for pathology, for proliferation and different markers. Since every patient has his own control and we have the 6-month follow-up, this should give us a clear view of what HCG does in these women. And so we are now planning to do an extension study, so to see if we have to prolong the HCG, and different protocols are going to be done. And then we are going to report, I heard around June, July 2018, where all the data will be available. And so we will be reporting on the website soon the progression of the study that will be available. Thank you very much.